Assalamu alaikum. Good morning. Today my topic is echocardiographic assessment of RV function. So importance of right heart dysfunction in various disease states are pulmonary arterial hypertension, pulmonary thromboembolism, secondary to left heart failure, left-sided valve disease, myocardial infarction with RV involvement, then congenital heart diseases, and ARVD and other systemic diseases. In case of MI, death, CVD, and heart failure, approximately 3 times higher in patients with RV dysfunction in comparison those who don't have RV dysfunction. These are the guidelines from which we'll discuss. So we all know the basic views of echo. So this is parasternal long axis view. And then this is the parasternal outflow view and inflow view. So we all see the LV as well as the RV. Then comes the short axis view at the level of the great vessels, then at the mitral valve level and papillary muscle level. Apical four-chamber view, so useful for demonstrating RV size, shape, and function. TRZ parameters can be measured in this view. Then comes the focus view, so measure the IV dimension here, and subcostal view. Subcostal view, RV wall thickness best measured, ASD-PFO best seen. This is useful for evaluation of RV collapse in cardiac tamponade. So right heart assessment, the parameters that can be measured include RA and RV size, RV systolic function, RV diastolic function, pulmonary artery pressures, pulmonary vascular resistance, then 3D RV volumes and RV strain and strain rate. So first come the right atrial measurement. So it is measured in major axis and minor axis. And major axis at the center of the tricuspid annulus to the center of the superior RA wall. It is the parallel to the interatrial septum. And the minor axis, the distance between the lateral RA wall and the interatrial septum at the mid-atrial level. It is perpendicular to the long axis. So measurements are a millimeter and minor area. So it is measured by tracing the RA blood intertissue interface, excluding the area under the tricuspid valve annulus. So upper reference limit is 18 centimeters square. Then comes the right ventricular function. So right ventricular function can be, these are the basics of RV. It is located behind the sternum, anteriorly positioned to the LV, and muscle mass is 1/6 of LV. Pumps blood against approximately 1/6 of LV. It is accustomed to low pulmonary resistance and hence to low afterload. It is a structurally complex cavity, fits no simple geometric figure, and RV size estimation required integration of multiple views and qualitative and quantitative assessment. So this is the qualitative assessment of RV size. And then comes the measurements. We measure by RV1, that is basal diameter, and it is measured at the maximal transverse diameter at the basal 1/3 of the RV. Then, and the upper limit is 41 millimeter. More than 41 millimeter is abnormal. And then comes the RV2, that means D2. So it is measured in mid RV diameter, measured at the level of the papillary muscles, and more than 35 millimeter is abnormal, and the RV length more than 83 millimeter is abnormal. And this is the measurement taken. And another one is our RV to LV basal diameter ratio. So it is taken apical four-chamber view, and ratio more than 1 measured at the end diastole suggests RV dilatation. So this is the RV. A four-chamber view, and this is the dilated. That was the normal RV. Here there is dilated RV. Then comes RVOT measurement. It is best viewed from the left parasternal long and short axis view. Should be measured at the end diastole. in QRS deflection. So diameter more than 33, proximal is considered to be abnormal, and distal more than 27 millimeter indicates dilatation. And then comes the RV wall thickness. It is seen in RV subcostal view, and measurement more than 5 millimeter is abnormal, and it is measured near the tricuspid valve. RV systolic function. So RV systolic function has been evaluated using multiple parameters, like we all know TAPC, then fractional area change, then TDI, derived tricuspid lateral annular S-wave velocity, and then comes RV index of myocardial performance, or RIMP, and 3D EF, and RV free wall or 2D strain. So TAPC is a M-mode cursor to be aligned along the free wall as perpendicular to the lateral tricuspid annulus as possible. TAPC is simple, less dependent on optimum image quality, and reproducible. Does not require any sophisticated equipment for prolonged image analysis. TAPC strongly correlate with radionucleotide angiography, and then Simpson, RVEF, and fractional area shortening. It is assumed that the displacement of single segment represents the function of the complex 3D RV structure. Less than 17 millimeter is considered to be abnormal. Then comes the FAC, or fractional area change. So it is obtained by tracing the RV in systole and diastole. It starts from the annulus, then along the free wall to the apex, then back to the annulus along the interatrial septum. So more than 35% is normal. Tissue Doppler imaging, S-wave. So a pulse Doppler sample volume is placed in either the tricuspid annulus or middle of the basal segment of RV free wall. More than 9.5 centimeters per second is considered to be normal. Tissue Doppler imaging measurement taken at the lateral tricuspid annulus in apical 4-chamber view, and basal RV free wall segment and lateral tricuspid annulus are aligned with the Doppler cursor to avoid the velocity underestimation. The disadvantage is that it assumes that the function of a single segment represents the function of the entire ventricle, which is not likely, is a condition that includes regionality of the RV infraction. So it will be erroneous in case of regional wall motion abnormalities in the RV. RIMP. So it is an index of global RV performance. So it includes isovolumetric contraction time, isovolumetric relaxation time, ejection time. It can be measured using the tissue Doppler as well as pulse wave Doppler. The tissue Doppler is preferred as it derived from the single sample and requires sample position at the tricuspid valve level annulus, like this. See here, you can calculate it from a single measurement, and the normal is less than 0.54. And for pulse wave, we have to put a cursor in RVOT and as well as the tricuspid annulus, but it requires the same heart rate, so it might not be possible. So comes the RV diastolic function. So it is from the apical 4-chamber view by pulse Doppler of the tricuspid inflow and tissue Doppler of tricuspid annulus. Measurement is similar like of the left side. We all know that. And here grading of RV diastolic dysfunction, EA ratio more than less than 0.8 suggests impaired relaxation. EA ratio 0.8 to 2.1 with E by E prime ratio more than 6 suggests pseudonormal, and E by A more than 2.1 and deceleration time less than 120 milliseconds suggests restrictive filling. It is similar like the left side. And another thing, tricuspid E by E prime more than 6 indicates that raised RA pressure. That is, RA pressure is more than 10 millimeter. And now comes the 3D volumes. 3D dimensional echocardiography is global measure of RV systolic performance, and 3D gives reasonably accurate estimation of RV end diastolic volume and end systolic volume, and RV ejection fraction. It is validated against cardiac magnetic resonance. In laboratories appropriate with 3D platforms and experienced 3D derived RV ejection fraction should be considered a method of quantifying RV systolic function. And less than 45% is considered to be abnormal. So this is the 3D imaging. Now comes the global longitudinal RV free wall strain that has been nicely demonstrated by Rakesh Gupta sir. So more than -20 is considered to be abnormal, global longitudinal strains of RV free wall. Now comes the pulmonary artery pressures. So pulmonary artery systolic pressure, it is measured from TR jet, we all know, and also from pulmonary flow acceleration time. So here we can see the large TR jet. Pulmonary systolic pressure by TR jet, pulmonary artery systolic pressure is equivalent to right ventricular systolic pressure in absence of RVOT obstruction. So pulmonary artery systolic pressure gradient between the RA and RV is equal to A plus RA pressure. And using TR jet, we use the simplified Bernoulli equation. So 4 into TR velocity square plus RA pressure. Pulmonary flow acceleration time is also less than 100 milliseconds, indicate the elevated pulmonary artery. We can also assess the severity of normal, and if it is triangle like with moderate, raised, and severe, you can get notch in the RV, TR. Here, see it is like triangular. And here you can see the notch. So it indicates severe pulmonary artery hypertension. Now comes the mean pressure. So it is measured from TR jet mean pressure and PR jet mean pressure. So mean pressure mildly elevated 25 to 35, moderately elevated 36 to 45, severely elevated more than 46 millimeter mercury. And PA mean pressure can be located by tracing the TR jet. So if we trace the TR jet, we get the mean and peak pulmonary artery pressure. So here, see the mean and peak. And another one is mean TR gradient plus RA pressure. So if you take the gradient and use add the RA pressure, you get the PSP. And there are some formulas that you can measure the PA pressure. And for the PA, pulmonary artery mean pressure. So it is taken from PR jet. So pulmonary regurgitation velocity represents the diastolic pressure difference between the pulmonary artery and the LV. Pulmonary artery mean pressure correlates with the early diastolic pressure difference between pulmonary artery and RV. So this is the PA, mean pulmonary artery mean pressure. And pulmonary artery diastolic pressure is the second deflection, and it is also measured by Bernoulli equation. That is, pulmonary artery end diastolic pressure is equal to 4 into PR end diastolic pressure velocity square plus RA pressure. It is the newer guideline. They suggest this early diastolic PR velocity more than 2.2 meter per second is considered a marker of raised mean PA pressure. So here is similar thing. Now comes the RA pressure. So RA pressure is measured by IVC method, hepatic vein flow, tricuspid valve Doppler. Raised RA pressure, you can measure from if there is dilated IVC, lack of inspiratory collapse, number 1, number 2, E by E prime more than 6, atrial septal left foot bulge, and predominant diastolic flow pattern in SVC or HV. So here, see the dilated IVCs. You can see this one here. As a smaller IVC. And the new guidelines suggest that the RA pressure measured if the IVC diameter is 21 millimeter or 2.1 centimeter less than that, and the collapsibility is more than 50. So it is the normal RA pressure. So that is 0 to 5. Average is 3. And for intermediate ones, if the diameter is less than 21 and the collapsibility is less than 50, or the diameter is more than 2.1 and collapsibility is more than 50. So these are the intermediate varieties, and the amount is 5. You have to add 5 to 10, or average 8. And high if the diameter, IVC diameter, is more than 2.1 and collapsibility is less than 50. So it is high, and you add RA pressure 15 millimeter. So comes the Doppler of hepatic vein. Doppler, you can see if you align the beam to the flow of the hepatic vein in a subcostal view. So you see the S wave velocity here, then D wave, D, that is the diastolic, and SR and DR. So that is the systolic and diastolic reversal. If normally Vs is more than Vd is normal RA pressure. If the systolic flow is smaller, so elevated RA pressure. Another thing, hepatic vein filling fraction. So less than 55, the high, we have the higher RA pressure, more than 8. I won't go through that. Pulmonary vascular resistance and elevation of systolic pulmonary artery pressure does not always imply the increase of PVR. PVR distinguishes elevated pulmonary pressure due to high flow from due to pulmonary vascular disease. So it is calculated from TRZ, and PVR can be calculated in echo. More than 3 significant pulmonary hypertension exists when PVR is more than 3 Woods units. And this is we can summarize the RV function. So here, TAPC less than 17 is abnormal. S wave less than 9.5 is abnormal. Fractional area change less than 35 is abnormal. And RV free wall strain more than -20 should be is considered to be abnormal. 3D EF less than 45 is considered to be abnormal, and RMPI more than 0.54 is considered to be abnormal, and for pulse wave more than 0.43, and E by E prime more than 6, it is also to be abnormal. So these RV function, it's a jumble of parameters. So if we calculate it in a cool way, so we can measure we can take all the parameters. So my take home message: though neglected, RV function assessment is very important for diagnosis and prognosis of many cardiac and pulmonary disease. Pulmonary hypertension and RV dysfunction associated with increased mortality in heart failure, COPD, and ILD. Proper assessment of RV function is an art. We have to give proper attention in this regard. Thank you. Thank you all.